Hello again. Welcome to the next edition of our series of lectures on systematic reviews. Today we're going to talk about meta-analysis, which is probably the part that scares most people when it comes to completing systematic review. Hopefully by the end of this lecture you'll be feeling a little bit more confident about meta-analysis and at least willing to give it a go. So, first question is, we're going to do a meta-analysis, why should we do it? One of the most important points about meta-analysis is it increases the power and precision of estimating a treatment effect. So essentially what it does is gives you a much larger participant numbers, which wouldn't occur if you have multiple low quality studies without doing a meta-analysis. So if you've got studies with 5 or 6 people per group, or 10 per group, or 20 per group, and you've got lots of these studies, many of them may be underpowered, which means we may not be able to find anything significant in terms of statistics. If we combine the data from these studies, then often this can lead to statistical significance, hence increasing the power of precision. The other thing is that it reduces the random error, so it can reduce our confidence intervals. So our narrow confidence intervals mean we can be more confident about the overall findings, particularly if there's common findings across multiple lower number participant studies. And if there's real differences that aren't being found by these studies in terms of clinical significance, then obviously it allows us then to produce statistically significant findings and hence create some far better and far more effective clinical guidelines. The other thing is that it will improve our confidence in the decision-making process as well. So if we've got multiple studies showing some significant, some non-significant, it can be very difficult to make a clear-cut conclusion related to the data available out there. So if we can combine this research together, then we can come up with one common finding across the board, and we can apply these conclusions to our clinical decision-making. So a lot of people say meta-analysis is great to read, great to see, and we can use them clinically and we can use them to understand the research, but to complete them ourselves, people often say, help, I'm scared, I'm confused, I don't know what to do. So what should you do if you're keen to do a meta-analysis as part of your systematic review? Firstly, listen today, obviously. Ask questions of those who have done systematic reviews before. Download RevMan. So RevMan's a free download which you can get online. If you just Google RevMan free download, it will come up. It's a great statistical package program which will be no charge to you, and it will help you complete your meta-analysis. We'll do another online tutorial on how to use RevMan. The other thing is there's some clinical guideline notes which will be made available to you online, and there's also the Cochrane Handbook, which is an excellent resource for those considering doing any systematic reviews, but in particular if you're looking and considering doing meta-analysis. The other thing is that RevMan also has its own guidance notes and its own handbook as well, so that's something worthwhile reading. So, decisions about meta-analysis. Firstly, we need to understand whether our data can be pooled. So this requires homogeneity between studies, which we'll go through a little bit more shortly, but essentially you need to have similar methodology in terms of outcome measures, in terms of participants, and also in terms of interventions. If there's discrepancies between these and the studies are more heterogeneous, then we may just group some of our findings together. For example, some studies looking at biomechanics associated with knee pain may look at measures of knee kinematics, but these measures may be different. So one study may look at peak knee flexion, another study looks at knee flexion range of motion, another study looks at knee internal rotation. So these three findings, if they're all associated with knee pain but different variables in terms of biomechanics, aren't appropriate to be pooled. So you may just group these together because it makes logical sense when it comes to the discussion that you're going to talk about them. So you might group these together in terms of when you complete your effect sizes and when you plot your forest plots. So what sort of analysis do we use for meta-analysis? Two main options. We can use effect size calculations or standard mean differences, and we can use odds ratios or relative risk statistics. So this is continuous data for effect size and standard mean difference, or for relative risk odds ratios, this would be more for your dichotomous data. Importantly, what these do is they standardise our statistics across the board regardless of outcome measures. So it allows you to compare the strength of findings across different studies. It also allows you to plot the findings using easy visual representation. So it's easy for a clinician to pick up and look, and they can understand findings, but also for a researcher to pick up and look and understand the findings. So as I mentioned, here's the download. So it's a free download on RevMan. Like I said, if you don't want to write this link down and enter it in, if you just Google free RevMan download, it will come up and you'll be able to find it. So how do we get started? Firstly, you need a clear hypothesis. As we've talked about throughout, we want to have some predetermined criteria for our systematic review and how we're going to go about it, and a clear hypothesis to guide your meta-analysis and data pooling is really important. You need to make decisions about where it's appropriate to combine studies. Really important to consider that differences in methodology, differences in outcome measures are the norm across studies. It's not the exception. So if we're going to do data pooling, we need to be aware that things aren't going to be perfect. So we're not going to have exactly the same outcome measure, exactly the same participants and cohort, exactly the same time points, and exactly the same interventions, or exactly the same control. So we need to be realistic about this, but certainly the things to consider is the population, so how well they are matched in terms of between the different studies, the methods, so time points, etc. Interventions, so are the interventions similar? So for example, an exercise intervention of strengthening, if there's minor differences, then we could possibly pool the findings. But if, for example, we're looking at strengthening interventions and we've got one study which is doing and looking at, say, a tendinopathy as an example, and we've got one study that's doing heavy load program, and we've got another study that's doing some TheraBand based exercise, it may not be appropriate to combine those studies. The other thing to consider is not just the intervention but also the control group. So some studies will have no intervention, others will have a placebo intervention, and we need to make decisions about whether or not we combine them. But certainly in a general sense, if the placebo you don't feel is going to provide anything great in terms of clinical effectiveness, then I would say possibly combine them with no treatment. But you need to make that decision on a case-by-case basis, and obviously discuss with anyone else involved in the systematic review that you're completing. And then finally, consider outcome measures. So some outcome measures are very, very similar. For example, pain VAS versus a pain rating scale on a scale of 1 to 10. So if you've got a 100mm pain VAS and you get the patient to verbally rate their pain from 1 to 10, you may be able to combine these studies quite easily because they are very similar in terms of outcomes. So that's also something worth considering. But if they're very, very different outcome measures, for example, one outcome measure may be pain VAS, another outcome measure may be a measure of functional performance and the patient's ability to do certain tasks, or a quality of life scale, then these may not be appropriate to pull together. Okay. Let's make some decisions based on our table here. So if we have a look, we went through this example when we talked about some previous systematic review methodology. So we've got a number of studies, so we've got 8 example studies here looking at the ability of exercise to improve outcomes in knee osteoarthritis. So we need to decide about what data we can pull together and what data we shouldn't pull together. So if we decide that we want to look at the effectiveness of exercise by itself without any other intervention compared to no treatment. So let's have a look and see what interventions we have to fit that mould. If we have a look at the first study, we've certainly got exercise here, but we don't have any comparison group. So we probably can't use that for our data pooling and what we're looking for. If we look at the second one, this also involves NSAIDs, so perhaps we don't want to look at that in terms of our data pooling here. If we go to the third one, we have exercise versus no treatment. So this fits our criteria for what we're after. If we go to the fourth study, so looking at Wodehouse here, then we've got again exercise versus no treatment. So we can pull the findings from here. And then if we go down further, we've got one with hydrotherapy and physical therapy, so we probably don't want to pull this one. And then if we go down further, again we've got exercise versus no treatment. So we could possibly look at pooling these 3 studies. So here, here and here with exercise versus no intervention. The other thing we need to make sure is we want to consider, are they similar participants? So we've got severe OA, we've got all grades of OA, and we've also got all grades of OA. So we could possibly say that they're relatively similar. If we go to outcome measures, we've got the Houston, and we've got the Houston. So this is probably quite appropriate to do some data pooling. Another example might be we want to know what the effect of exercise in addition to NSAIDs is. So is exercise plus NSAIDs better than NSAIDs alone? So we have a look here, we've got Elliott study which fits that mould. We've got another study down here which is Golding, which also fits that mould, and the bottom study also fits that mould. So have we got similar types of participants? We've got all grades of OA, all grades of OA, and we've got mild knee OA. So we might argue that maybe mild may not fit in with all grades, or we may say that that's okay, we're just going to take any knee osteoarthritis, so that's a decision we need to make. In terms of outcome measures, we have the Houston, we have a 6-minute walk test and a Houston. So it may be worthwhile combining the two Houston studies, but the 6-minute walk test may be considered quite a different outcome measure. So we may need to separate that from our data pooling. So this is what we need to think about when we're considering how we group our studies together in terms of discussion points, but also how we group them together in terms of deciding what data to pool. So hopefully you get through the process of making decisions about what your questions are and what you're going to pool, and this now leads to a simple or relatively simple two-step process. Firstly, what we do is provide summary statistics for each studies. So this is our effect size or standard mean difference, or if we have dichotomous data, this is looking at our relative risk stats, which we'll go through more in more detail shortly. So the other thing to do, the second part, is we then produce summary estimates where appropriate. So by summary estimates we mean data pooling. So what we want to do is see what studies we combined, as we just spoke about in the example with the table. Now when we come to producing a summary estimate, what we want to do is we usually use a weighted average of the individual study estimates. So you can use different models within RevMan, and this will become more clear when you start using it, but there's a fixed effects model and a random effects model. So fixed effects, what it does is it bases the weighting of each study on the size of the study. So if you've got 5 different studies, it will combine the data from all of those studies, and what it will do, it will give more credence to the studies with higher participant numbers. So that's a recommended process to go through when completing your meta-analysis. Other methods of weighting the studies can also be weight them on quality, so you give higher quality studies more influence over the pooled effect size or our summary estimate. The problem with this is that we probably don't necessarily have valid methods of deciding how this weighting should be conducted. So what constitutes a high quality study versus a low quality study is often quite debatable, so it can be quite controversial. So I think it's mostly, in most senses, easier just to use a fixed effects model and base it around that. So step 1 as an example, so this is a study which was recently published in BJSM, and this was looking at the onset of gluteus medius in individuals with patellofemoral pain compared to individuals without patellofemoral pain. So on the left side indicates delayed onset of gluteus medius in individuals with patellofemoral pain. On the right hand side would indicate earlier onset of gluteus medius in individuals with patellofemoral pain. So if we look across the number of tasks, we can see that during running we have a delay in onset. If we look at stair ascent, we've got a number of studies here, so far more than what we have for running, so we actually have 5 studies to compare. And what this shows is that 3 have a significant delay, we have 1 which has a trend towards a delay, and we have 1 that actually shows an earlier onset of gluteus medius. So these studies overall tell us generally it's delayed, but we also have 1 that possibly is leading towards an earlier onset. So this is where we might pull the data to see, and we'll look at that in a second. Stair descent, very similar. We've got 1 study which is significant in terms of delay, we've got a couple more which is showing delay, and another one which is not showing us much at all, so basically the same onset. For other tasks, single leg jump, we've just got 1 study. For lateral step down, we've got 1 study. So based on this, we can't make any real clear conclusions regarding stair ascent and stair descent as yet without doing some data pooling. Certainly running, we only have 1 study, and single leg jump and lateral step down, we only have 1 study. So we can probably confidently say, based on this, that it is delayed during running in individuals with patellofemoral pain, but probably no difference in single leg jump and lateral step down based on some limited research. If we go to step 2, and we can pull the findings, so ignore the single findings and we'll focus on stair ascent and stair descent. And what you can see here is that we now have a significant estimate or pooled estimate of a delay of gluteus medius in individuals with patellofemoral pain during both stair ascent and also stair descent. So we can relatively confidently conclude that in general individuals with patellofemoral pain have a delay in gluteus medius onset during stair ascent and stair descent. Obviously we need to acknowledge that it's not consistent across the board, but overall our pooled effect size shows that this is the case. So what about dichotomous? What about dichotomous data? So we use risk ratios for this. So this is relative risk or odds ratio. Generally we'll look at using risk ratio, and I'll talk more about the importance of that in a minute. But the data we need to complete dichotomous calculations, we need the events, so how many injuries occur in each group, and we also need participant numbers in each group. So we might have one group, for example, completing neuromuscular warm-up program to prevent injuries, and another group who's a control group who just performs normal stretching. So what we need is the number of injuries in the group who completed the warm-up program and the total number in that group, and we also need the number of injuries in the control group and the total number of participants in that group. From that we can calculate risk ratio or odds ratio. Now importantly, these are not the same. If events are rare, so less than 10%, there'll be minimal difference between the two. If events are more frequent, the differences can be quite large. Now I won't go in depth into the differences between these two, but certainly if you read through the Cochrane handbook, etc., you can learn a lot more about this. What I will make the point of is that risk ratios are far more understandable by both patients and clinicians, so probably the preferred method to use, and certainly something that's used more commonly in the literature. So in simple terms, if you have a risk ratio of less than 1, you have a reduced risk of something occurring. If you have a risk ratio of greater than 1, then you have a greater risk of something occurring. So if the risk ratio was 0.5, your chance would be half. If it was 0.25, your chance would be a quarter, or 25%. If your risk ratio was 2, you'd be double. If your risk ratio was 4, you'd be 4 times the risk. So nice, simple, easy to understand by both patients and clinicians. It's also really good with this form of statistics to complete number needed to treat. So what this would show us is that how many times we need to apply an intervention in order to have one more successful outcome. So for example, a number needed to treat of 3 would mean that we have to apply an intervention such as neuromuscular warm-up program in order to prevent one more injury. So it's a nice simple method of allowing both patients and clinicians to understand the research again. Now there's lots of internet-based calculators, so this is not something you do through RevMan, but if you just Google number needed to treat calculator, there'll be loads come up on the internet, and you'll be able to use one of these to help you to calculate them. So risk ratio is an example. So this is a systematic review recently published, which we looked at the effects of neuromuscular warm-up programs on injury prevention. There's a number of different programs, so you can see here on the left different programs. So we've got the KIP, the 11+, the 11, the PTP. And what we've got here on this data is we've got the overall injury incidence and overuse injury incidence. And what this shows us is that the KIP program was able to reduce our injury risk. So if we look at our risk ratio, it's 0.50. So basically, completing the KIP program halve your risk of developing an injury during the season. And this was in soccer players from memory. If we look at the 11+, 0.67, so you were 67% the chance of an injury compared to if you didn't complete the program. A couple of the other programs completed, there was no change. Here you've got the KIP again, so you've got 0.44 and 0.45 for the 11+, so basically 44% and 45% respectively in terms of injury risk compared to if you didn't complete. As we mentioned before, if for example our intervention was not a success and actually went the other way, then we might start to see some risk ratios of towards 2, which would mean you'd have double the chance of developing an injury. So what do you do if there's no events in one group? So if you come across this, you'll find that it doesn't actually calculate your risk ratio for you, and they simply won't work. A standard process to go through is to add 0.5 to each group or cell, and that can certainly allow you to then at least get some sort of statistics associated with your outcomes. Alternatively, you can just report you're not able to calculate the risk ratio because there were no injuries in the intervention group, which would be quite promising if there were quite a few in the control group. So that's also a consideration. So continuous data, we use something slightly different. So what we actually do is we use a standardised mean difference, or effect size, and essentially this is the mean difference between the groups divided by the standard deviation. So it standardises things, which means that you can compare and contrast very different outcome measures. So the data we need for this, we need the group and or condition means, so whether that be pain VAS, whether that be a functional outcome measure. We need the standard deviations, and we need the number of participants in each group. So if we can collect that data from the paper, then we can complete effect sizes. Generally, when it comes to using dichotomous data, you will find that most of the data will be within studies and there shouldn't be too many issues. When it comes to continuous data, often there will be data missing. It might be standard deviations missing, participant numbers are usually there, or it might be means missing. This is particularly the case when studies rely on using graphs in order to present their findings. If this is the case, one way around it is to contact the authors and see if they can send you the means and standard deviations. If it's not possible to get the data, then it's not possible to complete the effect size calculations, unfortunately. But you certainly need to try and make some sort of effort to get it if you're going to do a high quality systematic review. So an example here, so this is a systematic review where we looked at the effects of pre-cooling on outcomes in terms of performance for endurance activities, so running and cycling generally. And what this shows us, and this is a really good example of data pooling, a lot of low participant number studies, so we've got 7, we've got 11, 10, 8, so quite low, and this is looking at time. And what it shows us is that across the board, pre-cooling, so looking at ice vests, looking at ingestion of ice slurries, tends to improve our outcomes in terms of performance, but generally non-significant. Out of the 4 studies here, only 1 is significant. But if we have a look at the pooled effect size, we actually have a significant outcome. So the point being, for something to be significant, it must not cross this 0 line. So here we've got a 0.64 outcome. So what that means is that we've got a moderate effect size showing that by having some pre-cooling intervention, we're able to improve our performance. If we look towards power output, 2 non-significant findings, and we have a trend towards a significant finding for power output, but certainly not significant as it crosses the line. So this is the same for your dichotomous data. If we're crossing the line, which is automatically put in by the program RevMan, then we're not having any statistical significant findings. So other things to consider. So there's a number of other things to consider with your meta-analysis. Crossover or repeated measure trials are slightly different in terms of statistics, and we'll go through that in a second. Heterogeneity in terms of not just study design, but also in terms of statistical heterogeneity, so different findings across different studies. So some may be significant, some non-significant, or you may have studies which show completely opposite findings. So one study may find something positive for an intervention, while the other study shows that the intervention is actually detrimental. Sensitivity analysis, which in short just allows us to answer a few more questions, and then publication bias. We all know that generally things that have a positive finding are more likely to be published. So we'll go into these in more depth now. So crossover trials or repeated measure trials. Statistical methods should be based on one group, so paired statistics in the original study. Unfortunately, in terms of risk ratio and effect sizes, these are actually based on 2 groups, so unpaired statistics. So what this means is you're going to end up with wider confidence intervals compared to when you use paired statistics, and it's a more conservative approach when you're completing your meta-analysis. So in simple terms, you may find something that is insignificant, but the study reports that there is a significant difference or a significant effect of a certain intervention or a significant change. Now, when you do your effect size calculations, it doesn't match up. So the point being that you need to be aware of this and know that the statistics that you're applying using RevMan and your meta-analysis are more conservative. It doesn't mean that you don't do them, it just means that you need to be aware of this when you're completing it. And it will help make far more sense, so you're not sitting there pulling your hair out while you're getting different findings to what the studies are reporting. The other thing is we want to look at statistical heterogeneity. So this is automatically produced within your graphs, so the I-squared, and this gives a percentage of heterogeneity. It's based on chi-squared statistics. So basically it indicates a higher percentage indicates more heterogeneity. So if you've got a low percentage, that means the statistical differences between the studies are very minimal, and we can be far more confident in our pooled effect sizes. So some people would say that if you've got high statistical heterogeneity, you shouldn't pool the data because the findings are too different. Probably the key thing is to take this into consideration when you're determining your levels of evidence. So for example, if you've got low statistical heterogeneity and a certain finding versus high statistical heterogeneity and a certain finding, then if there's high statistical heterogeneity, you probably should determine lower levels of evidence for that finding. In general, if you've got a p-value of less than 0.1, so not necessarily 0.05 but less than 0.1, which would indicate a higher statistical heterogeneity, consider possible reasons that this is occurring and go back to your pooling considerations. So it might be that your pooling has been inappropriate to begin with, so go back and consider if it's still appropriate. If you determine that it is still appropriate, then obviously you're going to have a few things to discuss as to why these differences in statistics may have occurred. So an example of exploring heterogeneity, so this is a systematic review we looked at patellotaping for patellofemoral pain. And if we have a look at this, we can see you've got completely different findings across 4 studies compared to one lone study. So this systematic review, or this particular forest plot, looks at the effects of taping on internal knee extension moment. So essentially how much load is going through the knee during a range of tasks. And you see we've got step up, we've got vertical jump, we've got a unilateral squat, we've got stair ascent, and we've got stair descent. So during stair ascent, stair descent, during a vertical jump, during a step up, we have significant differences in terms of it increased the amount of knee loading. If we look at unilateral squat, there is a significant difference also, but it's the complete opposite direction. In fact, knee loading reduces with patellotaping. So if we just look at this as is, it can be quite confusing. Certainly high statistical heterogeneity, we've got an 80%, so quite a high rate. But when we actually think about the methodology between the studies, it is actually quite different between our lone study versus the other 4. So in the other 4 studies, what we actually find when we look at the methodology is that there was no control in terms of rate of movement, etc. So by that, what I mean is that they were told to step up, but that was the only cue they got. It wasn't controlled in terms of speed. Vertical jump, they were just told to jump. Height wasn't controlled, timing wasn't controlled. Stair ascent and stair descent, again, they were just told to walk up or walk down the stairs. And when we actually look at the study findings a little bit more closely, what we find is that when we apply patella tape, not only does their loading go up, but also their cadence goes up and down the stairs. So what this means is that they're walking up and down the stairs at a faster rate, and they're actually taking more load through the knee because of that. So possibly the taping is actually allowing them to do that. Now when we look at the unilateral squat, this was controlled in terms of depth and in terms of rate. So the amount of load or the amount of stress going through the knee has been exactly the same, and the amount of load on the patellofemoral joint has been reduced by the tape. So if we go back and we think about this, we might say, okay, maybe it's not appropriate to pull all these together. So let's take the Mustermann study out with the unilateral squat where they controlled things, and all of a sudden our effect size goes from 0.37, which would be considered quite small, to a reasonably high effect size of 0.87. So this is something where you need to think, if you have got large statistical heterogeneity such as this example, have a really close consideration as to why this is occurring, and go back and see if you need to reconsider what goes into your pooled effect sizes. So sensitivity analysis, what this essentially looks at is, does including or excluding certain studies alter findings? So very similar to what we just did there in terms of we excluded one. But for sensitivity analysis, you can consider a number of different things. So it might be that lower quality studies may be impairing your findings, so we might divide into lower and higher quality studies. The advantage of including lower quality studies is you get a lot more data, but the disadvantage is it may confound your results. So often, if you are including all studies and not excluding based on quality, then reviewers in the past, we've found, have often asked us to complete a sensitivity analysis based on this to see if it affects the main findings of the studies. Now, if it doesn't affect the main findings that you conclude in your review, then you've obviously got far more data, it's stronger, but if it does, it might be something you need to reconsider. The other thing, you might have different participant characteristics. So for example, You might be looking at an intervention in patellofemoral pain, but we might think that perhaps gender has an influence on whether an intervention is going to work. So we might have some studies which have mixed genders, some studies which have male-only participants, and some studies which have female-only participants. So to begin with, we might just combine them all together and we come up with a certain finding. But then we might want to look further and see if there is an influence on gender. So we do complete the same meta-analysis using females only, and we complete the same meta-analysis using males only. And from this would give us an indication about the influence of gender on outcomes with a certain intervention. The other thing that it might be a variation in intervention. For example, shockwave therapy is something that's being explored a lot more both in clinical practice and research, and some of the thoughts are that higher levels of shockwave will lead to better outcomes. So we might use higher dosage studies and combine them together versus lower dosage studies and combine them together, versus combining all the studies together, and see if there's any difference in terms of outcomes as a result of this sensitivity analysis. The other thing might be outcome measures. The other thing could be sponsorship. For example, there was a really good systematic review done a number of years ago looking at glucosamine, and when they looked at all the studies combined together, glucosamine was shown to be effective and shown to assist in reduction of pain, etc. So what they did is they went back and they said, okay, let's just take the sponsored trials out and rerun the analysis. So they did that. So there was unfunded study, so no conflict of interest, and what it showed was that glucosamine probably didn't help. When they included sponsored trials only, then what they actually found was that there was an effect and glucosamine did help. So there was a conflict of interest there which was having a big effect in terms of the reported results. So this is something to also consider as well. So in terms of an example of sensitivity analysis, if we go back to our systematic review we completed on neuromuscular warm-up programs for injury prevention, if we have a look at distal injury, so medial tibial stress syndrome, ankle and ankle sprains, Achilles, what we found in our systematic review was that there didn't seem to be any effective programs that were able to reduce injury. Now, one of our criteria for entry into our systematic review was that the studies were required to be easily implementable. So by that it means that there was no additional equipment needed. So basically anyone or any club could complete this warm-up program without too much effort. So one of the reviewers actually questioned, well, what about studies that do include equipment, because we think that does work, and we thought, yeah, that's a good idea. So we completed the sensitivity analysis, and what we found is that when you add wobble boards, in fact there are some programs that are effective. So what this tells us is that without any additional equipment, then current injury prevention programs, at least in the research field, don't seem to work. But with additional equipment such as wobble boards, you can see that we're able to reduce ankle sprain quite a lot, and in fact a risk ratio of 0.23, so your risk is less than a quarter by completing a neuromuscular warm-up program, including the use of a wobble board. So that's quite a good finding. So certainly sensitivity analysis can be an important part of your research question or your review question. So thank you for your time on meta-analysis today. I hope you've got something out of it. Next step is to download RevMan, do plenty of reading so you understand what you're doing as well in conjunction with this video. There'll be a tutorial video on how to use RevMan in basic terms, in terms of entering references and data, which will be made available to you, so have a watch of that. And the main thing is just get stuck in and start using it. It's something that requires practice. The first time you use it, you spend a lot of time toing and throwing, trying to work out what you're doing. But like everything in life, once you learn how to do it, generally it becomes much, much easier. So just get in and have a go. Thank you, and we'll speak to you again soon.